Today, for me, it's a pleasure to present this study, the factors associated with the survival of patients with cancer and HIV in Cali, Colombia. In my country, the first case of AIDS was reported in 1984, 3 years after the first reports of the disease in 1981. According to UNAIDS, it is estimated that 200,000 people of all age with HIV diagnosis live in Colombia, and 12,000 new cases are diagnosed annually. Different studies have shown that people living with HIV has a higher risk of cancer than the general population. With the emergence of combined heart therapy, morbidity and mortality from HIV-related disease have been drastically reduced. According to analysis of the AIDS situation in Colombia, no AIDS-related neoplans occur in 0.74% of people living with HIV, while the frequency of AIDS-defined neoplans were as follows: Kaposi sarcoma, 1.76%, Burkitt lymphoma, 0.54%, and invasive cervical cancer, 0.14%. The estimates include data from the primary data generating unit, which capture the occurrence of events of public health interest and subsequently reports them to the public health surveillance system and to the high cost fund. Nevertheless, there are other globally recognized sources of high quality information, such as cancer registries. Therefore, there is a need to use high quality and continuous collect information to understand cancer in people living with HIV. This study aimed to determine the factors associated with the survival of patients with cancer and HIV in Cali, Colombia. The methods. A retrospective core study was conducted at Fundación Valle del Lili, located in Cali, Colombia. Data from the HIV database was processed with the data from Cali Cancer Registry between 2011 and 2019. All neoplasms identified by the Cali Cancer Registry were included. Patients under 18 years and those with limited available clinical information on diagnosis and treatment of both HIV and cancer were excluded. All cases were characterized based on the information in the medical record, the hospital-based cancer registry database, and the Cali Cancer Registry. A total of 322 patients were identified by matching the high cost fund database and the Cali Cancer Registry between 2011 and 2019. A total of 145 patients were excluded due to incomplete information, no HIV diagnosis or discarded diagnosis, no neoplans or discarded diagnosis, age younger than 18 years, or the presence of a non-oncological tumor. Finally, 173 patients with HIV and cancer were included in the study. The median age was 43 years old. 84.39% were male. The most frequent comorbidity was hypertension, and a total of 50% smoked and 11.56% used alcohol. There were 33 patients who had diagnosis of cancer prior to 2011. In the majority of cases, the cancer occurred prior to diagnosis of HIV, 61.85%, while the 9.25% case, the cancer occurred at 1 year after the HIV diagnosis. Regarding AIDS-defined neoplasm, the most common was non-Hodgkin lymphoma, followed by Kaposi sarcoma and cervical cancer. The most common location and other neoplasms were the anus and anal canal, 6.36%, and prostate 3.47%. 88.82% of patients had undergone some type of treatment, chemotherapy, surgery, and radiotherapy. And a total of 16.56% had at least one assessment for palliative care during their hospital stay. And a total of 68.79% had an AIDS-defined infection. We found difference between alive and dead in the following three factors: AIDS-defined infection, no AIDS-defined infections, and oncological treatment in the bivariate analysis. In the survival analysis, the median follow-up of duration was 1,136 days. Overall survival was 76.43%, and 1 year, and 64.25% at 5 years. Significant difference were found when subgroups were compared according to the presence of AIDS-defined infections and oncological treatment. Finally, the Cox regression models that include the diagnosis of AIDS-defined malignancies, AIDS-defined infections, and oncological treatment showed that infections decrease survival as a ratio 2.31, while the oncological treatment increased as a ratio 0.32. In conclusion, in people living with HIV, cancer is one of the main causes of morbidity and mortality, although its incidence is decreasing as a result of advancement of heart and cancer treatments. Non-Hodgkin lymphoma and Kaposi sarcoma are the most common neoplasms in this population. Factors such as infection associated and not associated with AIDS has been identified as a determinant of survival. Cancer treatment seems to improve survival. Information system of both HIV and cancer should be strengthened so that decision makers have data to strengthen public policies and public health strategies for people with these diseases. Likewise, the timely diagnosis of cancer in people living with HIV should be strengthened, as this can favor their survival. Finally, I'd like to thank you, Universidad ICESI, Fundación Valle de Lili, Cali Cancer Registry, and Universidad Católica Santiago de Guayaquil. Thank you very much.